Hello and welcome to the second session of the EBM course. In this presentation, I will talk about the introduction to evidence-based medicine, different concepts in regarding the introduction. First, the objectives. The objectives of this presentation are, at the end of the presentation, the participants should be able to define evidence-based medicine, delineate the purpose of evidence-based medicine, narrate brief history of evidence-based medicine, discuss sources and levels of evidence, explain the grade to assess quality of evidence, explain the 5 A's of evidence-based medicine, and explain the PECOT or PECOT, a clinical question acronym. I want to start with a quiz question. Which of the following items are components of evidence-based medicine? You may select one or multiple components to check your own knowledge, and give yourself time and see whether you checked correctly. Then follows the definition. There are several definitions of evidence-based medicine. One is made by the McMaster University in 1990. It says it is an enlightened skepticism toward the application of research to day-to-day management of patients. So somehow the research, the evidence we got from the research should be applied into our daily practice. How it should be done? It should be by an enlightened skepticism. You will hear a lot about this name, David Sackett, and he said it is a conscientious, explicit, judicious use of current best evidence in making decisions about care of the individual patients. Seeing this diagram here will make it maybe more understandable what we mean. Both these previous definitions include actually these 3 components: the best evidence, which is coming from the research, then our input as healthcare professionals, the clinical expertise, and patient values. So all these have to be merged together, integrated somehow to come up with the best possible decision for the patients and with the patients. So for and with the patients are the key words here in evidence-based medicine. I have a case vignette, an 80-year-old woman with lung cancer, she has some problems with the respiration, breathing. She has dyspnea. And if you look at the literature, it says if the bronchi are narrowed by the cancer tissue, then you can apply a stent to allow breathing. And this is expected to improve the quality of life, although it does not prolong the survival. So what we would do, most of us would, of course, go for this procedure, this intervention. But what if the patient does not want? What if the patient says she chooses to go home and receive supplemental oxygen and morphine? Of course, in this case, your duty as the doctor is to make an evidence-based medicine with your own experience, but together with the patient. And therefore, we say evidence is never enough. It is necessary, but not sufficient we have to consider also the patient's viewpoints. And of course, the setting and the resources as well. The purpose of evidence-based medicine is what? You know, there are wide variations in practice, often not related to differences among the patients. So the same patient goes to a doctor, a hypertensive, a diabetic, whatever, sore throat patient. One sore throat receives antibiotic, the other one not. One hypertensive patient receives one antihypertensive, the other one some other medicament. What is the reason of this? And what are the consequences of these variations? So the reason may be related to the beliefs or experiences of the practitioner, of the doctor, or how we interpret the evidence, or variation in response when evidence is uncertain, because sometimes we have not, mostly actually, we don't have certain evidence to make a conclusion. There is always a place to move or decide by the practitioner. Evidence-based medicine in this regard will help to minimize the variations in this practice. And of course, at the end, it should improve the quality of healthcare delivery and patient outcomes. Another quiz. Now I move from the definition further. There is an EBM organization established in 1972 after Cochrane. Cochrane is also a famous figure in evidence-based medicine. What is the name of this organization? Take yourself time and make a choice, a decision. It is the Cochrane Collaboration. Cochrane has said, "It is surely a great criticism to our profession that we have not organized a critical summary by specialty or subspecialty adapted periodically of all relevant randomized controlled trials." So from this point emerges the need for summarizing evidence, making it available for the practitioners and using it as evidence-based medicine. On the other hand, what is EBM not? It should not be considered as a cookbook medicine. We should not think that, okay, if you have the evidence, you take it and you apply it, and no, never forget these three circles, huh? The doctor, the patient, and the literature, the evidence. So we have to always keep all these three in mind. It is not a cookbook medicine, or neither it is only RCT's meta-analysis, because later in the slides I will mention that RCT and meta-analysis, these are high-ranked evidences, better evidences. All kind of evidence is valid and applies. Surely it is also not an obsession with criticizing papers. It will be cases, conditions where you don't need an evidence, like the example here published in the BMJ. You don't need to prove that with jumping from the airplane without a parachute will be lethal. Another quiz. Who is a Scottish doctor who conducted one of the first ever clinical trials? Is he R.K. Cochrane, James Lind, or Bradford Hill, or Semmelweis? Give yourself time. I will not answer the questions here, but you will be provided with the answers. So, going further to the history Of course, there might be other scientists in the history which we don't know, which is not recorded, but to the available knowledge, to me at least, when I was preparing this course, I think James Lind is the one who made the first ever clinical trial. What he did, let us read. On the 20th of May, I took 12 patients on board of the Salisbury at sea. So this is a ship traveling long distances. The crew of the ship, they have always the same dry food to eat. And they all in general had putrid gums, the spots and lassitude, with weakness of their knees, and had one diet common to all. So this is his observation. He observes the problem in the crew. And what he did, he placed 2 sailors, each on a different diet. One group received cider, and you may find it funny which kind of groups he established. The other one, elixir vitriol, sea water, vinegar, oranges and lemons, nutmeg, garlic, etc. So 6 different groups of people he established. Then they continued 6 days under this course, taking this new regimen, additional food. The consequence was that the most sudden and visible good effects were perceived from the use of oranges and lemons. And this, of course, although we don't see this disease anymore, but it is a famous condition in the medical literature taught in the books. Okay, another quiz. Who is the Hungarian physician? This is also about the history. Hungarian physician and scientist known as the pioneer of antiseptic procedures. He initiated hand washing. Hand washing is a very important practice in medicine, yes. Give yourself time, and here comes the answer. There is a condition known as puerperal fever. Women after delivery, they have infections, fever, and sometimes leading to septicemia and death. And so it was thought that it is to be miasma, contagious power that has an independent life of its own. But Inge Semmelweis noted that women whose babies, on that time, doctors, some babies were delivered by the midwives, some others by the medical doctors. And the doctors had some other duties, namely what? Namely, autopsies. They were making autopsies, the medical doctors. And right after making autopsy, touching the dead body, they didn't wash their hands, and they came and helped the woman to deliver the baby. And he observed that those delivered by physicians had far more often 12% puerperal fever than babies delivered by the midwives, because midwives did not have anything to do with the autopsy, with the dead bodies. And he found out that there could be a connection between this touching to the dead bodies and helping in the delivery. So he abolished in 1847 this practice and instituted chlorine-based hand washing, which is still a very useful disinfectant material, which we use in our daily practice, also at home or in health institutions. With this hand washing and chlorine disinfection, they could decrease the puerperal infections very much. Here's a picture of the autopsy room and Dr. Semmelweis pictured as washing hands. Okay, there are in the history, of course, in medical history, a lot of practices which were proven to be ineffective. That means the evidence is changing, constantly changing. So we have to follow the literature and see whether there is something new. In 1980s, there was this procedure, extracranial or intracranial bypass surgery to prevent stroke. They thought logically, if I can do bypass to the heart vessels, occluded heart vessels, why I don't make a bypass for the brain vessels? So, but in 1985, just 5 years later, and randomized controlled trials showed that the only actual effect was increased postoperative complications. So it was not as useful as it was expected. Yes, near to the end of the history of evidence-based medicine, I must remember, of course, David Sackett. Who is this guy, this handsome man? He is regarded as the father of evidence-based medicine. He founded the Oxford Center for Evidence-Based Medicine, and he passed away in 2015. I think it is important to know these short, small historical informations. You students, you may ask yourself, why do I need EBM? Why it is necessary? Until this stage, I try to give some explanations to make clear that it is necessary. But if you plan to see patients, if you plan to be involved in medical treatment, help patients to make better decisions, or even if you don't, if you are planning to take some decisions for yourself, your own health, the health of your loved ones, the family, the peers, the friends, the neighbors, then of course you have the responsibility to practice, base your decisions on evidences. Therefore, I think evidence-based medicine is necessary for all medical practitioners, not only medical doctors, all nurses and other allied health professionals. We in medicine, we deal with these four actually main titles. Either we do a diagnosis, a therapy, or we try to prevent harm, or sometimes the patients are asking us some information about the prognosis, and then we need to give the answer on prognosis. So the current evidence, we can classify the current evidence in these four categories: diagnosis, therapy, harm, and prognosis. And also this course, the sections of this course will be based on these four sections. Another quiz. In these slides, I have many quizzes, yes. Please name 2 study designs with the highest evidence ranks. So there are different study designs, like cross-sectional studies, cohort studies, case control studies, randomized control studies, etc. And these have their evidence rank. What are these ranks? Here they come. Here they come. There is this pyramid called the hierarchy of evidence. And this one is taken from the Cochrane. And as you see, on the tip of the pyramid, the best evidence, the strongest evidence are what? Systematic reviews, or these we call also the meta-analysis. The meta-analysis, the systematic reviews. Then comes Critical appraisal appraise topics like evidence synthesis and guidelines. Then critical appraise individual articles, and thereafter we have the randomized control, the individual study designs, randomized control trials, cohort studies, case control studies, and at the bottom of the pyramid we have the expert opinion. That does not mean expert opinion is not important. It is the base, it is very important, but there must be something built above it. Consider a house, a building. You have the basement, but no windows. That would not be nice. Huh? So you need also to support the expert opinion with the different study designs, preferably randomized controlled trials, or even more preferably, a systematic review of the randomized controlled trials. The evidence levels are categorized, and this is the most commonly used categorization provided by the Center of Evidence-Based Medicine as 1A, 1B, 1C, 2A, 2B, 2C. I don't expect anybody to remember all the definitions here, but I believe it is very important that even as we categorize the different the importance of the different study designs, we also need to know that even within the study designs, if you have a question to answer, then you collect the medical literature, you make a review, you come up with a conclusion. This conclusion will have also its different evidence levels. Do you have a systematic review of randomized controlled trials available supporting a decision? Then that means you have a 1A, the best level of evidence, but that's not always possible. After we have the evidence, the best evidence or whatever evidence we have, we need to make a conclusion, a recommendation. And these recommendations, also based on the evidence, have their grades. If you have very strong evidence to make a good recommendation, then you call it the grade A recommendation. Grade A means consistent level 1 studies. So here we have the level 1, 1A, 1B, 1C. If there are many consistent level 1 studies, then you can conclude on a grade A recommendation. Then we have the grade B, C, and D level of recommendations. Of course, as we go from A to the D, the level of the strength of the recommendation becomes weaker. Good. One more quiz. Can you give some medical practice examples that have proven wrong, as this bypass, cranial bypass, for example? Do you have some other? Just think a moment. You will find, I'm sure, even lay people will remember some medical suggestions which later were changed. Why it is changing? Because this is the nature of science. Science is not static. It is not a dogma. It always is open for new evidence, new investigations and changes. And unfortunately, in medicine, that is very fast, and therefore we have to keep ourselves up to date always. Here, one interesting quotation: half of what you are taught as medical students will in 10 years have been shown to be wrong, has said the dean of the Harvard Medical School. And the trouble is, nobody knows which half. So it It may be 10 years, 5 years, 2 years. That's not the question. But important is that to accept that medical knowledge is very fast to decay, and we have to update ourselves with new evidence. Another example for this change is the hormone replacement therapy. Hormone replacement therapy was introduced in 1960s. I remember I graduated in 1991. When I was a medical student, it was still in practice. Hormone in some schools, some hospitals, even a routine practice to administer hormone replacement therapy, estrogens, to women in menopause. Only in 2002, it was shown that it had more harms than benefits, and we should stop this practice. Then it was abruptly stopped because the doctors had fear that to harm the patients. But today we know that in some selected indications, we may apply hormone replacement therapy or hormones just locally as creams. My last slides, also another quiz. Which of the following is the first step in practicing EBM? Asking the right question, acquiring the evidence, appraising the evidence, applying the evidence, or assessing what we have done. Actually, here I have given the circle with the 5 pillars, 5 components of evidence-based medicine. Evidence-based medicine starts with asking an answerable clinical question, asking a question, then acquiring the best evidence, collecting the evidence, appraising and deciding, is this evidence high or low, is it strong or weak, and then applying this in our practice, assessing what happened, did it benefit, should we continue this practice, and always follow the circle from the beginning. Therefore, some titles in this course will be taken actually from this slide. So, since the first step in practicing EBM is asking the right question, I must finish with this presenting this slide about the PICO. They may call it also PECO, PICO, PICOT, PICOTT at the end, double T's. But once you have understood what it means, it is very easy to remember. The P stays for, so each question must have these 4 or 5 components. First, if you ask as a doctor a clinical question, you must mention in your question your patients, your population, or the problem you are addressing. Then the intervention and exposure, the intervention, exposure, and the comparison, because at least 2 groups should be compared to come upon a new decision. So intervention and comparison. And finally, and most important, is the outcome of interest. What are you trying to change? Are you dealing with mortality? Are you dealing with fever, like puerperal fever, pain? What is your objective to change with your practice? And of course, the T's stay for type of study. That means the evidence rank, and type of question, because we have mainly two types of questions, the background and foreground questions, but this we will discuss in our future classes. So here, one example to make it more clear to understand PICO. You are caring for a 25-week preterm infant. The infant is ventilated and has an oxygen requirement of 60%. Mild to moderate cardiomegaly on X-ray and a murmur. So as smart students, when you read the story until this, you probably have a diagnosis in your mind, assumption at least. And when you, after doing the echocardiogram, we prove that there is patent ductus arteriosus. What to do with patent ductus arteriosus? First, let us ask our question. What is the evidence that in preterm infants at below 1,000 gram birth weight, a hemodynamically significant patent ductus arteriosus treatment with indomethacin compared to no treatment will result in closure and avoid surgical ligation from randomized controlled trials? So I extended this question actually a little bit to include the T here, but without the T, it would be my objective, my outcome is whether there will be closure of the septum, of the patent ductus arteriosus. This is my objective. What I want to compare, no treatment, just observation, and indomethacin, because we know that indomethacin is helpful in the closure of the patent ductus arteriosus. But even without indomethacin, a significant proportion of these patients will heal. And what is my population? Here I describe the population or the problem, preterm infants with PDA. Okay, that was for PICO. Now, of course, nothing is perfect. Also, evidence-based medicine has its limits. And one limitation is it is time-consuming. Everything valuable has its price, and this valuable information, knowledge requires time, of course. You need to have also some resources to go and to find the evidence and to read it, access medical literature. As I said, as we have given the example of Cochrane, Cochrane is not free. So, but there are also free resources. So, access to medical literature. Knowledge of epidemiology and statistics. Without any statistical or epidemiological knowledge, you will not be able to understand the p-value, the confidence interval, the study designs. This will all will be very unfamiliar to you. So these basic requirements are also a limitation, can be considered as a limitation. Of course, there are publication bias. Not all medical literature is 100% reliable. What we need from the resources we read, there will be some which will be proven wrong later. Unfortunately, there are sometimes some scientists, some research papers have also conflict of interest. They are supported by some organizations which have economical interest in selling a product. And therefore, we have to be very careful what kind of evidence we are looking at. If there is a conflict of interest, we should stop reviewing it. Then there might be the case of no evidence available, and it is always with uncertainty. Even if you have the best evidence, there will be some uncertainty. In summary, these were our objectives at the beginning. I hope you will be able to reach these objectives by following, by listening, reading this presentation. Thanks for watching.